Well, we are discussing the prostate gland. In part 3A, I covered the zones and lobes of the prostate toward the end with the help of the drawing. Now in this part 3B, I intend to discuss more of the zones and lobes, and additionally I will be discussing other aspects of the gland, and there may be some recap also. Last time I mentioned that there are many people who believe that anatomy is a static subject and it does not change. It does not change. Well, the anatomy itself does not change, but the applications, interpretations, materials, methods, instrument, equipment of studying anatomy are ever changing. Not only that, even the terminology is also ever changing. And sometimes the anatomy itself is simple, but it is the terminology which makes it complex. Now, with these few words, I will now share the screen and get to the PowerPoint presentation, which I could not finish in part 3A. Now, let us go to the PowerPoint presentation, and I share the screen. Here it is. And this is the very first slide. Well, sagittal section of the pelvis, and I do not intend to discuss further about this. Just we look at the prostate, where it is. Here it is, along with the prostatic urethra. And then we go to the next slide. And in this we discuss the location and approaches to the prostate gland. Approaches surgical and other. I may add that apart from the approaches which we have covered, there is also transperitoneal approach through that region and reaching to the prostate, transperitoneal, through the peritoneal cavity. Extraperitoneal is also there when we consider the laparoscopic surgery and robotic surgery. So these are some of the newer approaches which we did not cover last time. Now, I go to the next slide. In the latest Terminologia Anatomica 2019, several terms have been recognized for the description of the prostate. As for example, which surfaces are there, apex, base, lobe, etc. Even the zones are covered, and we have already discussed about this. in part 3A. And T8 2019 depended heavily on Mars et al.'s 2010 article. Next one. Old is gold. Taught 1907, very nicely depicted ejaculatory duct. At that time it was called, and we were also using the term common ejaculatory duct. Not that these ducts are very close to each other. Whenever we take a transverse section of the prostate, we store the duct very widely separated, and accordingly the zones are modified. So we should keep in mind that the ducts are, though running downwards, forwards and medially, they are quite close, and they cannot be seen completely like this in any section because of their obliquity. Fine, we go to the next slide. And here is a specimen from our museum, and seminal vesicles there, vas deferens, that one, and below them, this is the prostate gland. This is the urinary bladder, superior aspect, and on the posterior aspect, which is called base of the urinary bladder, seminal vesicles and vas deferens are located, right and left. Base of the bladder is at the back. Base of the prostate is at the top. Apex is below. And the next slide. And here the glands are shown, and I will not go into further discussion on them, we already covered. And here grants diagram of the distribution of glands, and we can see the mucosal, the submucosal, and finally the prostatic gland proper. 3 sets of glands. And well, if you want to see the label which I have given after modification, those are the labels. Okay. Fine. And this is from 1963. And this transverse section will help to some extent in defining the zones of the prostate. Next one. We already covered the historical lobation of the prostate by Lockley 1912, and I do not intend to discuss further about them. The lobes have been studied by Lockley in fetuses, and they are not applicable to the adult anatomy. And this slide was the last one I think I presented in part 3A, or let us find out. Yes. Now these are the zones. I again show the zone. Here are the zones. Around the urethra, the transitional zone, which is supposed to be around 5% of the prostate substance. Around the ejaculatory ducts, the next zone, central zone, is supposed to be around 25%. This one. And more laterally here and peripherally, the peripheral zone, which is about 70%. Even if you add 5, 25, 70, ultimately you have to give space for this anterior white fibromuscular stroma. That zone, this one, the spine, which is about 1%. And in this, the interior of the prostate urethra, prostatic urethra was discussed. This is the pre-prostatic urethra, usually ignored, but I have covered it. And apart from that, the prostatic urethra, along with the prostatic utricle, which some people regard as not uterus but vagina, vagina masculina. And the elevation, the yellow one which is shown here, is called verumontanum, mountainous ridge. It's the most prominent part of the entire yellow urethral crest. And in the next diagram, the median lobe of the prostate is shown. And if this is enlarged, then there will be an elevation behind the internal urethral orifice called uvula vesicae, obstructing the flow of urine. Well, we go to the next slide now. And this is the last one from the previous presentation. And I have left some gaps, and I call them gaps of knowledge and maybe my ignorance. Now, I have modified this diagram, and that is the first slide actually of this discussion. Here it is. And you can see around the proximal prostatic urethra here, transitional zone are shown. It is all around that. And now this is the lateral section. At the end, this is the transverse section. I have shown the transitional zone all around the prostatic urethra. Only upper part, remember, proximal part of the prostatic urethra. Then I have shown with reference to the ejaculatory duct, the blue color, the central zone. You can see there. And the right and left you can interconnect. I was not sure of that. When you draw, you realize where there are difficulties. So, now, after referring some articles, I concluded that the right and left should be made continuous. Central zone, about 25%. And peripheral zone, in brown, everywhere, here it is. Maximum, 70%. And between the right and left peripheral zones, at the front, there is anterior fibromuscular trauma. That is also a zone. This one, yellow. In sagittal section, if it is median or even little bit of the midline, you can see that one, but you can't see the peripheral zone. So this is schematic. Remember that. And here I have not drawn the peripheral zone at the back, but as the ejaculatory ducts run forward, downward and medially on their way to the prostatic urethra, when they are very near urethra, very big gap is left behind them, and that will be filled up by this brown peripheral zone. The zones have great clinical significance. The benign prostatic hyperplasia occur commonly in the transitional zone. In that case, it will become highly enlarged. Some people call it hypertrophy, but most consider it as hyperplasia. You have to find out the distinction yourself and get better idea from the clinician. Benign prostatic hyperplasia. That is from the transitional zone. The peripheral zone is prone to malignancy, carcinoma, peripheral zone, and orthochronic prostatitis. It does not mean that the various diseases which I mentioned do not occur in other zones, but they occur most commonly in the zones which I have already discussed. Well, in a single section you can't see everything, remember. These are all schematic sections. That to be kept in mind. The way the urethra and ejaculatory duct are shown here, you don't expect to see them in a single section. Sagittal or coronal or transverse. Is that fine? But they can be dissected out. The zones are based on study of hundreds of prostates, remember that. And there are histological and histochemical differences between them. Not only that, even in MRI, it is possible to identify these zones. The ideal thing would be to have MRI of the prostate from top to bottom and serial MRIs. That would be the ideal thing to have. And then somebody who knows MRI interpretation will be able to identify the zones. We go to the next slide now. Lobes and zones, difficult to correlate. But because previously we were knowing only about lobes and we were discussing only lobes, and subsequently the zones were described. Lobes by Lopley, 1912. Zones by McNeil, from 1968 onwards, McNeil had written several articles on zones. So we try to correlate, and this one is from Sharma et al. 2017. Central zone means median lobe and posterior lobe. Transitional zone, median lobe and anterior lobe. Peripheral zone, lateral lobe and the posterior lobe, the lower part of that. And anterior fibromuscular substance, most of the anterior lobe. Fine. And this is, if you dissect from the back and open the rectum, in front of the rectum you find the prostate gland. So rectum is utilized for particularly digital examination, digital rectal examination, PR, and also for ultrasound, and there may be other uses. And apart from them, at the higher level, the bladder and vas deferens, right and left, and seminal vesicles are also shown by April 1957. And the muscles which are shown, particularly the levator ani muscles, will be very important when you consider the relations of the prostate and how the nerves can be preserved during surgery. Next one. Now this is again the per rectum examination. One can feel the prostate there, and if there are any nodules, they can be palpated, and then further investigation can be done. Again, look at the location of the prostate, which may be just 15 grams in weight, but it goes on increasing in weight, and it may reach even 150 grams or even more. It's an ever-growing gland, and we have not covered the age changes, and we are not going to cover them further. Is that fine? And next one, again the same thing, but different kind of view. You find the prostate here. This will be good for perineal approach, isn't it? So basically, anal triangle and urogenital triangle are there, and we go to the next slide. Now, before I show any structures here, I would like to discuss further. Well, in benign prostatic hyperplasia, the prostate is removed by the root of urethra. In the most common surgery that is done, other approaches, surgical approaches are there, but this is common nowadays. Transperineal resection of prostate, TURP. The prostate is removed from inside, and the capsule is kept intact. Well, prostate gland and thyroid gland are compared many a time regarding the facial coverings. we used to discuss that both the glands are covered by true capsule, a part and parcel of the gland, and false capsule furnished by the local fascia. For the prostate gland, the local fascia was called pelvic fascia. For the thyroid gland, the local fascia was called pretracheal fascia. And it was always discussed that between them, in case of the prostate gland, between the true and the false capsule, a venous plexus is located. And that's why if the prostate is removed from inside, excavated from inside, keeping the capsule intact, then the venous plexus is not disturbed and damaged, and that can prevent excessive bleeding. Now the terms have changed, but I think that part of the anatomy is still same. It remains the same. The entire prostate is removed along with the seminal vesicles and vas deferens and some nodes in radical prostatectomy. In that surgery, it is important to preserve the neurovascular bundles, and particularly the nerves which are going to the corpora cavernosa, right and left. So cavernosal nerve. So very important in such surgery is maintaining the continence and the potency. After surgery, there should not be incontinence and impotence. So where are the neurovascular bundles located? Prostatic capsule is labeled here, and I will now show those. The pioneering work was done by Wolf et al. 1983, and one of the first article was by Wolf and Donker, and I have modified it little bit. Fine. This is the prostatic capsule. The black line, you can take it. And other side is also available. And it must be tough to identify it. Outside that, you find the prostatic fascia. Well, I have put a line there, yellow, and till outside this one is the lateral pelvic fascia or levator ani fascia. Similarly, on the other side you have to look. Okay, and the neurovascular bundles are in that location. They have to be preserved. And veins, arteries and nerves are together, and they may be helpful in identifying the nerves and in taking the incisions in this region in case of radical prostatectomy. At the back, there is denon-villus fascia, we have discussed previously, which in the midline may be fused with the prostatic capsule, and so the incisions which are described are intrafacial, that will be outside the capsule. The yellow line is that. The interfacial and then extrafacial, all of them are there. And for the benign hyperplasia, we have described that the prostate is excavated from here. So you have to refer to various articles beginning from Ward's 1983 to get perfect idea. Very important, the dorsal venous complex. In ligating that, the sphincter should not be damaged. Sphincter should not be damaged. Sphincter is very complex. There is internal urethral sphincter, there is external urethral sphincter, but there is no real urogenital diaphragm as we have considered previously. In the prostatic urethra, the sphincter should not be described as pre-prostatic. Some people have described. In fact, urethra is there even before the prostate develops. Prostate develops from the urethra. And that urethra before prostate development is pre-prostatic. But in the adult, when we consider, we know that there is one pre-prostatic part of the urethra just below the bladder, about 1 to 1.5 centimeters long. And sphincter which is there can be called as pre-prostatic. But once the urethra is in the prostate, we should not use that term. The prostatic urethra has both smooth muscle sphincter of 2 layers as well as in the lower part the striated sphincter, which is continuous below with what was called the sphincter urethrae, a part of the urogenital diaphragm. And then the next slide, some references I have selected, and here they are. I already referred to Losley, 1912, then McNeil, 1968, and here are those references. And obviously, the 42nd edition of Gray's Anatomy can be a good reference. The anatomy published in 2021. I have also included the Gray's Anatomy for Students, 4th edition, and Losley, McNeil, several articles. If you want to get better idea about Birilas and Kandelacki's article on urogenital diaphragm. Now, why that was an erroneous concept, you will get good idea in this article published in 2004. And for various terms, Myers may be consulted. These 2 articles are there, and for the urethral sphincteric muscle in the male, Orange, 1980 article is referred by many, and already I have covered everything. And the last reference that I want to point out is by Jakub and Otto, published 2018, which even the Gray's Anatomy has included. MR imaging of the prostate zonal anatomy. And because of the copyright laws, I have not included that excellent diagram. I think that will complete this PowerPoint presentation, and I stop sharing and the concluding remarks as I go for them. I have handled everything here single-handedly. This time I wanted to stand. That's why it was not very easy, and handling the mouse and computer and keyboard and everything. And I just find out if I have missed anything. I think the surgeons who are going for the radical prostatectomy would like to visualize the nerves which are microscopic, and that's why laparoscopic and robotic surgery, where you find magnification, there can be, the nerves can be seen and then saved, which is not possible otherwise. Apart from that, multiphoton microscopy is a new method of seeing the nerves. And another method, optical coherence tomography, is also under development. So several other methods are developing so that at the end of the surgery, the patient does not suffer from incontinence and impotence. And let me see if I have missed anything. I just look at that. Well, I have not used the term intramural part for the pre-prostatic urethra. Remember, that is given by Gray's Anatomy, but I found it confusing. I have avoided that. The first part. So now the male urethra is not 3 parts. It has 4 parts. And the membranous part is sometimes called intermediate part. And okay, another new method will be fluorescent peptides, but I do not know further about that. I think this is all that I wanted to cover in this part 3B. So we have in all 4 parts in which we have tried to cover many important aspects of the prostate gland. Thank you very much.